members attending, which there are none, both in person and online, will have the opportunity to ask a question when the relevant agenda item is being considered. To ensure everybody has a fair opportunity to participate, that we must make sure, the best use of the time available. Members will be permitted to ask one question on each agenda item. If you wouldn't mind introducing yourself, thank you.
Thank you, Chair. My name is Nikki Turner. I'm the Managing Director of the Isle of Wight Division of Hampshire and the Isle of Wight Healthcare NHS Foundation Trust. I'm just going to allow my colleagues to introduce themselves before we kick off, if that's okay, Councillor Eamon.
Hi everyone, I'm Lucy Abel. I'm Clinical Director. Quite often that's a medic by background. I'm actually a speech and language therapist by background.
Sorry. Hello everyone, I'm Eugene Jones. I'm the Chief Operating Officer for the Hampshire and Isle of Wight Healthcare Trust. I'm an executive member on the board.
Hello everyone, my name is Susie Marriott and I'm the Chief Nurse at Hampshire Isle of Wight Healthcare NHS Trust. I'm also one of the execs on the board.
I think just out of interest of the people that are potentially watching online, Laura, would you mind just explaining the difference between what the local authority does and what the NHS Trust does with regards to healthcare on the island? Thank you.
Does this one work? Yeah. Excellent. Sorry about that. I'm sure they'll wake up in a minute. In terms of the split between mental health support for people who live on the Isle of Wight, it's a three-way thing. The local authority, as adult social care, have a number of responsibilities. The NHS Trust, through the Community Trust and the Acute Trust, have a number of responsibilities. And there's a third cohort of responsibilities that align to the work of the approved mental health practitioners, the AMPs. The local authority has a duty to provide AMPs for the Isle of Wight, but the work that they undertake is entirely within their own remit. It is not controlled by the local authority, nor is the local authority responsible. They're probably the easiest cohort of people to talk to you about first, and the duties of the AMP relate to assessment of people's mental health for detention. They're actively involved in working with NHS colleagues, with doctors, to determine whether somebody needs to be detained under the Mental Health Act legislation in a secure environment. If we park that to one side, you then end up with general mental health duties around people who live in our community. The local authority's duty under the mental health remit is no different to its duties for citizens under the Care Act. There are two minor changes, and that's in terms of funding for ongoing care and support after a person's been detained, which is shared jointly between health and the local authority as adult social care. The adult social care duties relate to the provision of care and support in exactly the same way as the Care Act relates to other people who live within our community with different primary reasons for support. So, for example, people with physical disabilities or challenges with their cognition and their memory. Our health partners have responsibility for treatment of mental health conditions and for supporting people through diagnosis, through assessment of those conditions, and for providing health interventions in the same way your GP has for providing interventions in relation to your health. So there are two very distinct parts of the mental health landscape locally. For the local authority and for health partners, there can be some blurring of those boundaries where a person is going through an assessment process and has care and support needs. There's a need for the local authority to work really closely with NHS partners and on occasions with approved mental health practitioners with AMPs to ensure that full support is in place for that individual. But the local authority's obligations extend to those Care Act principles around care and support to help people to maximise their wellbeing and promote their independence in the community. Does that assist you, Chairman?
Thank you very much. That's very helpful. I hope that's helpful to the people online and the people listening. I will hand over to you, Nikki. Thank you very much.
Thank you very much, Chair. And thank you for inviting us to speak on this matter. We've responded in a report, which I'm going to take as read, to the questions that the committee has rightly raised to the Trust. But there are some elements that we particularly want to emphasise, explain, and give some examples of what we're doing, particularly as a result of the CQC recommendations over a number of inspections. So all four of us are going to talk. It's a bit of a moving feast. Who's going to talk next? So bear with us. I'm in charge of the slides. They are up. hopefully either side, and you can see them. If they're not big enough, we do apologise. We can certainly circulate them. I've already shared them as well, Chair. So Eugene is going to kindly kick off.
Thank you very much, Eugene. Please carry on.
Thank you, Nikki. So yeah, just a bit of an introduction to the trust. I think in the pack you'll see that the trust was formally established in October 2024. That doesn't necessarily tell the whole story, in that we've been working in alliance and partnership with colleagues on the island with regard to mental health services for many years prior to that, in a allyship and alignment with support and functions. Actually started initially with the initial CQC inspection some 7 years ago, which rated the services inadequate for mental health on the island, and there was a partnership going on from that time, which we've continued to evolve and develop. We are providing community mental health and learning disability services into the organisation as a whole, so we support the whole of Hampshire and Isle of Wight through that lens. And that was very much the drive of the integration and bringing together and forming the new trust, the opportunity to make sure that unwarranted variation, differences in practice, issues around funding and resourcing and staff and rotas and resilience could all be responded to within the one lens of the new organisation that was formed. And that's really an important aspect that we're taking forward. We are about providing more joined up care and consistency as a result of that. The pathways in terms of mental health, notwithstanding Laura's point around our interface and joint work with the local authority, the pathways for mental health are ours to designate. And we have a number of different divisions across the trust to provide that. The Isle of Wight is a division in of itself for the trust, and then oversees all of the mental health and community aspects of care on the island that we provide and are responsible for in the trust. We've got a 5-year strategy which has just been launched last year in 2025. The kind of key drivers around that are improving population health, delivering outstanding care, enhancing staff experience, and ensuring value for money. And they apply in every aspect and every area of the provision and care that we provide across Hampshire and Isle of Wight. We were ranked nationally 11th out of 61 mental health and community trusts within the NHS oversight framework, which is a new mechanism to establish essentially the performance of NHS organisations. There's a league table, and that's where we pitch within that. And in the terms of the CQC, go on to the body of that I think shortly in the due course. But out of the 16 services that were rated, 13 of them were rated good or outstanding. So more work to do, but I think it's certainly moving in the right direction from our perspective. I'll hand over now. Thank you.
Thank you, Eugene. I'm just seeing if my mouse is going to work. Where's the way it fails at the last moment. So just a little bit of a reflection on island services themselves. As Eugene rightly said, 18 months ago, the services transferred between two trusts, but the partnerships across the island remained really, really strong. Isle of Wight Trust, primary care, local authority, of course, voluntary sector, and particularly working closely with Health Watch. We really focus on how we can drive and improve change. So I did want to say, all feedback we really value, because it's the insight, whether it's from an individual carer, a patient, another partner, helps us have insight to change our services and to improve our services. So that's very much what we're about. And our focus at the moment are on two particular areas that weren't rated good at this point, which is our community mental health services and our crisis resolution home treatment teams, and our place-based health-based place of safety, which we will explain in a minute.
Just sorry to interrupt, Nikki. Do you mind just bringing the microphone just a little bit closer?
Slightly closer?
Yes, please.
Apologies.
Thank you.
It's unusual for me to be talking quietly, so thank you for drawing attention to that. So from an Isle of Wight division perspective, we have over 1,000 members of staff, and they all contribute to the delivery of safe and effective community, physical health services and mental health and learning disability services on the Isle of Wight. We really are focused because of the unique geography, working in partnership. We cannot deliver services on our own. And I think there is very much a strength in our relationships and how we deliver care. Our particular focus has been around addressing the challenges on the island, and you can't think of one in isolation or in isolation of the other for the example of physical health or mental health. So again, a really big focus on the island around improving, particularly around the community services we provide, how we provide it and how we treat patients, and also how we support patients and families and carers in crisis. We can't do that also without our wonderful workforce, and our workforce again that works in partnership with others on the Isle of Wight and also wider within Hampshire. And just a personal reflection from me, having the opportunity to work across a number of trusts on the island and off the island, the value of working in a bigger organisation that has that breadth of expertise to support island residents is really, really important. And I think you'll get a flavour of the positive impact that that is having, and I expect will continue to have as we go through the presentation. So I am handing over again, I think, to Susie.
Thank you very much. Okay, so what we've done in the next slide is theme the areas of concern from the 3 CQC reports where we got requires improvement. So that was our well-led assessment, which was conducted last year in November. So it's about a 3-month period when the CQC do surveys, focus groups, they speak with our stakeholders as well, and then they do a number of inspections throughout our services. And they're looking at culture, governance, and sort of the leadership of the services, health services. And then the other 2 reports was our community mental health report, where we had requires improvement, but also our crisis services and our health-based place of safety. So what we did is theme the areas of concern that were brought up by the CQC. The first one is under governance and organizational learning. So the well-led assessment specifically identified governance systems are in place, but still embedding. So we were still in the transition phase of us joining the 4 quite complex organizations together. And they certainly saw that we hadn't quite bedded in our governance approaches. And service level findings showed that there was inconsistent incident reporting, delays in recording incidents, and various feedback really from staff. We had very, very good feedback from carers and patients, but our staff was still struggling with the merger. So they certainly had a lot of feedback from our staff about the concerns. The next theme was workforce culture and leadership. So they said that they found that there was an impact of organizational culture, leadership visibility, and staff well-being as well. So quite a few staff were sort of found the merger quite a difficult experience, and we were just coming out of that. And many staff reported that they struggled with seeing leaders. They didn't see that the leaders were visible. So we've actually we've produced our people plan, and we have a particular focus on leadership and succession planning with a very intentional, visible leadership approach now, sort of to combat those concerns that the CQC identified. There were also concerns identified around care planning and patient carer involvement, risk assessment documentation across the trust, and sometimes there was difficulty locating discharge plans. There was variation in care planning. That was the quality and the type of care plans as well across the organisation, and they were not always personalised or holistic or recovery oriented. And some family and carers were not as involved as they should have been in the care planning process and involved in providing care, and their voice was not always heard. We also received feedback around access, flow, and capacity. So findings highlighted issues relating to responsiveness with our crisis services, our health-based place of safety, and urgent care pathways as well. And again, the discharge process came up here too. There were also concerns found around digital records and information continuity, because we are operating several EPRs still across Hampshire and the Isle of Wight. And this was causing some concerns with transferring information across different services. And it was causing frustration for staff as well. So we are moving forward with procuring a new EPR across Hampshire and Isle of Wight. And then finally, safety fundamentals as well. So there were recurring themes around safety controls, which included environmental safety, equipment checks, seclusion and ligature compliance, and also mandatory training as well of our staff. So what we've done since we've received the reports, we've actually introduced a very robust action plan across the trust, which is led from within the division. So the divisions have been very involved in this process and really targeting the areas of concern within their services. So what I'm going to do now is hand over to Lucy, and she's going to talk about that.
Thank you. Oh yes, microphone.
Oh, sorry.
Thank you. Yeah, this slide just gives a visual of kind of how when the reports came in, the lime green boxes tell you kind of what's happening in terms of that trust action planning that Susie's just referred to. And then the green ones are what we're really focusing on right now, which is signing off our local plans for crisis. That was the last one we've been working on, our crisis services action plan. The acute mental health, that one was quite a while ago. That CQC report good, but there were still things we've been working on together. And then our CMHT one as well. Work has started on that, but we're kind of reviewing and making sure we've got everything kind of finalised, updated, and then we kind of monitor that through our monthly governance meeting. In mental health, they have a performance and quality meeting every month, and then we review the outputs of that and the physical health one in our monthly divisional oversight group. The Trustwell-led action plan has been developed, and on the island, it really kind of chimed with the feedback we'd had through our own staff engagement sessions. So we had a staff survey report, and there were quite a lot of themes that are similar. So we've said Nikki's going to mention sort of the work we've been doing there. So it's kind of a mixture of work we've been doing anyway, as kind of local quality improvement, work we've been doing as this new organisation where we're looking at pathways and trying to improve, and then through the CQC we're then focusing on these specific action points. So for each of the regulatory action, there's a task and finish across the trust, and then we're monitoring those in the division as well. If I tell you a little bit more about the two specific mental health teams and what we're doing. So the community mental health team is where we offer our real core but specialist community mental health provision. So we have 3 teams across the island, one based from Newport, one based from Ryde, one based from Sandown, and they provide kind of specialist care to people with ongoing, enduring mental health problems. And so our primary care colleagues, they see people and hold people until the risk is too high, and then they come into our community mental health team, and our teams probably would see people, the most often they might see them is once weekly. That's the sort of level that we're talking about. If someone requires more support than weekly, they would step up into one of our crisis teams. So the things we've been working, and CMHT was one of those services rated as required improvement. So our leadership team have been linking into the trust-wide work, been looking very much at waiting times for service users. Say the demand on the service is high, and what we've found more than it just growing and growing is people have become more complex with kind of perhaps with neurodiversity as well as a mental health problem, and it's just meant that flow through that service has slowed down a bit and our caseloads have grown bigger. So we've been doing some really targeted work of reviewing those caseloads, and in particular this month reviewing people that have been on our caseload a really long time, because we have got some people we're holding far too long, which then means we can't pick up the new people at speed. Excuse me. Within our community mental health team, we have psychological therapies, and this has been an area where access was particularly challenging. Done some work around reducing that. The team benefited from being in the larger organisation by kind of seeing what peers were doing, and they kind of already knew what they needed to do, but it gave them the confidence they were doing the right thing. And we paused referrals for a short period while they reviewed everybody on the caseload, did sort of a sort of discovery phase, worked out what they really needed, and that's made a really big difference already. We're not quite where we need to be, but we've gone to a point where our average wait is 35 weeks. That sounds long, but we are in a much better place than we were. And our longest wait is 154 weeks, which comes down to a number of reasons, probably between the person and the team, of whether it's the right time to do it. But that was 249 a year ago, which kind of made us all very, very uncomfortable. We think we'll have those waits back under 6 months by January next year. So it's not an immediate fix, but going in the right direction. Our clinical oversight of waiting lists is much more robust. We had a divisional change where we brought in increased clinical leadership and oversight of our teams. So that grip has really improved, but still has a way to go. Looked at how we support people who are waiting. So there's an organisational waiting safety framework. For us, what that means locally is we have trigger points for each service and level of risk where our healthcare practitioners contact the person waiting, has a conversation, updates their risk assessments, and will support and signpost while they're waiting. Done a lot of work around risk reviews, and that's something our divisional Director of Quality and Professions, who couldn't be here today, is supporting and working on, and did some very targeted work on the island and in the other divisions to drive that up, and that is now at a much better level. It's a 95% target, and we're there or thereabouts now. Working with our mainland colleagues to agree a new standard operating procedure, which will describe those escalation processes and try and make sure there is kind of similar consistent processes happening everywhere. For us, we do have the additional challenge of that body of water that makes it harder to recruit staff. Our CMHT does have a number of vacancies. That is a real challenge. So again, our corporate HR colleagues have been helping us in terms of coming up with creative ideas, funding travel ideas, much more exciting adverts and different ways of doing things. So that is helping us, but I have to acknowledge that that is still a challenge for us. If I move on to our crisis teams, the crisis teams, as I say, pick up people where they need seeing that day. They might need seeing within a couple of hours, 4 hours that day. So we've really focused on the island around recruitment of our leadership for that team. We've got a new operational lead, and we created with skill mix review 2 clinical leads. So again, we're trying to really bolster the clinical leadership for our teams. Again, through skill mix review, we've created another specialty doctor. So in old descriptions, that's a middle grade, so not a new trainee, not a consultant, but someone who's a senior decision maker in their own right. And we've recruited, we've shortlisted, and are interviewing in another couple of weeks. That will give us 4 another adding to our acute and crisis specialty doctors, which will really support. One of them will then we'll go from having half a doctor to a whole doctor for the crisis team, which will be will really help in that leadership. Again, that governance and safeguarding is kind of cross-working across the organisation and locally, and we've got much better at monitoring those crisis response times. So some of that is just detail of how we collect it, and the crisis team does really well. It hits its target all the time, so the response is good, but there's a challenge in meeting the demand all the time. And linked with this is the health-based place of safety. So that is, we have one health-based base of safety based at 7 acres. So that is a suite where the police will usually bring somebody who they have detained under what's called a section 136, where there's somebody is at risk to themselves or others, and they'll go there until they can have the Mental Health Act assessment done in conjunction, as Laura described, with the AMPs and the adult social care teams, and then a decision is made, do they need to be detained and admitted to a bed or supported in the community? We only have one on the island. Our population dictates that's all we need, but sometimes there is more than one person who is at that level of mental health crisis. So then people are taken to the emergency department at St Mary's. So if that is your loved one, that doesn't feel brilliant, and there can be a delay whilst the assessments are done. And then if a bed isn't immediately available, we might have to seek a bed somewhere else. We've done a lot of work. Before Christmas, we had some staffing issues and we're having to close the place of safety, R1 at 7 acres, if there weren't enough staff. We've addressed that, and since January, we haven't had to close it due to any staffing issues. It will not be available now, only if somebody is already occupying it. And a bit further down the road, we are looking at options. It'll be very exciting if we can get there with some national funding to extend that. We only need one 136 week, but we could do what we'd really like is a kind of urgent assessment area that has a bit more flexible space. So that there'd be a kind of seclusion type of area, and then there'd be assessment rooms and perhaps very short stay kind of bedrooms. So that isn't say in the next year or so, but we can certainly update you as we move forward with that. So I'll hand back over to Nikki.
So, Lucy, don't we'll get the hang of it. I just wanted to focus on the last couple of slides. One was around workforce, and we've all mentioned the importance of workforce, and popped a couple of pictures up. They're not the most up-to-date pictures, but the Isle of Wight division and a lot of our staff do really well at being recognised for what they do, whether that's qualifications, whether that's just going the extra mile. We have an annual awards celebration, and this year 3 of our staff actually won the Healthcare Hero Award. So I did want to mention one in particular, and some of you might be aware of her. Her name's Roxy, and she got the Rising Star. So one of the things as a division we felt was really, really vital was to grow our own workforce. And we developed a service called Careers for Young People. So we source and look for people at children at around 16, 17, just finishing their GCSEs, that maybe not quite sure what they want to do. And we offer a number of apprenticeships. We're actually at the moment just offered for our 5th cohort. And in doing that, they undertake a pre-apprenticeship for 6 months, where they get experience across all healthcare services. And that's not just clinical services, that can be business services, operational stuff as well. And then they go into a longer term apprenticeship for a further 18 months. I'm really, really pleased to say we've got a number of that are permanently now employed across healthcare, and others that are starting their nursing training. So I just go back full circle to Roxy, our rising star. She has completed her apprenticeship, she's permanently employed, and she's about to start her nurse apprenticeship. So we're giving our youngsters the opportunity to explore careers within the NHS, and take a sort of safe step forward into developing longer term opportunities for them. As I mentioned, we're on the 5th cohort now. Because of the success of this, we were awarded a King's Award alongside HTP, and we're currently rolling out this programme across the other divisions within the trust. So there's a lot of good stuff going on in the island that we're sharing, and there's a lot of learning and opportunity we're grabbing from our other geographies and from our other specialist services. So I just wanted to mention that in particular. But what's really important to Lucy and I as two of the triumvirate, so there's three sort of leaders within our division, Natalie being the third who couldn't be with us today, is our visibility in what we do. We have a number of sites that were based on across the island. In that original slide, I popped up a little diagram, and we're all over the place, and it's really important to us that we're out there with our teams, talking to our teams. We also have a face-to-face meeting. Come and talk to us, talk about anything you want to, ask questions of us. So it's a sort of talk to the try sessions, and we do also a lot of online sessions because everybody's all over the island, senior leaders, but also all staff meetings as well, to talk about what's going on, not only within the trust, but also across the division and across partners and partnership working on the island. So we try to get out there as much as possible, and we try to inform as much as possible. We've got, I don't know how many of you use a lot of Teams and WhatsApps. We've got channels that are active 24/7. Things pop up. People are always problem solving and helping each other out. And that's just the nature, I think, of the community we operate in. Lucy and Susie also mentioned around attracting workforce to the island. I gave the example of let's grow our own. Certainly within the medic workforce, we're looking at how we can develop middle grades, as Lucy described, into those full-blown consultants who want to stay and work on the island. But also we're looking at different roles across our services as well. We're looking at adapting. So because we're small, we can pilot, we can test, we can learn, and then we can scale up on the island. And then our other divisions can also learn from us as well. So we're trying to be quite innovative, we're transformational, and we absolutely spend a lot of the time in the partner space saying, actually, how do we do this together? It's vital we work collaboratively. The final point I wanted to particularly mention on this slide is the importance of people with lived experience. Again, we've grown this on the islands. We have a number of people that work within our services that give that insight, that work alongside people within 7 acres of secure units, and support them and work them and understand and have a perspective on their journey and how they're feeling and what their needs are. So that's being expanded into the wider trust as well. So again, that's something that we think is vitally important. So that was just a bit of a flavour. I also just wanted to finally sort of touch on, before I move on to the final slide, on freedom to speak up. We have a great freedom to speak up team for the trust that regularly comes to the island, talks and goes and visits and sees and speaks to our staff as well. And we find that that's really vital. They have a really broad perspective across Hampshire and Isle of Wight. Again, they help share insight and learning, which is really vitally important. We do a number of staff engagement sessions. When we do that, we also have the opportunity of having a box on the side, which is anonymous. If somebody wants to pop something in and tell us something and they can't speak to us, then we do that as well. So
Thank you. Please, can I move on to the summary, please? Thank you.
Yes, I'm going to the final slide. Thank you for allowing us to just complete with a few more words. So in summary, the Trust has action plans. We have submitted them to the CQC. At a local level, we're very focused on the described within the report, and hopefully today, where we as an island are focused, and the learning will be shared across the divisions as well. There are common themes, and we are working collaboratively to address those. The Isle of Wight team, we have 20 to 30 years worth of experience on island. So we have a local team that understands the local communities and really wants to collaborate and work not only within the trust, but across partners as well. We're keen on growing our own. We really love any ideas about how we attract more people to the island to come and work within this fantastic community. So I will stop there. I'll just check with my colleagues to see if they want to say anything else. Otherwise, we'll hold there. Thank you.
Thank you, Nikki, for that comprehensive outline on the. We've got some questions. Before we move on to questions, just before we start the meeting, I didn't mention that we actually have water available on the back there. So please, members of the committee and guests, feel free to stand up at any time in these questions to go and refresh yourself with water. Thank you. I'll kick something off, and then I'll kick off with the first question and hand it over to the committee afterwards, and we'll see if we can get a discussion going on. I'm sure there are lots of questions that the committee would like to ask you. So you mentioned on one of the your slides the digital records and information continuity and safety fundamentals. Inspections highlighted recurrent themes related to core safety controls, including environmental safety, equipment checks, seclusion, ligature compliance, and mandatory training. I've been to your facility, which is fantastic, the new facility. I'm assuming that's talking about the old facility. Is that correct?
I would think this is probably talking about our mental health inpatients, so 7 acres.
7 acres.
Yeah.
So would you be able to explain to the committee the discrepancy with the funding, the health investment in the community, 7% currently on the Isle of Wight, when the national average is generally about 12%? Are you able to give that explanation as why give us an explanation? That'd be great.
So from the statistics I've got, Councillor Whelan, the ICB, which commissions us as a trust to deliver mental health and physical health services across Hampshire and the Isle of Wight, spends 9.1% of its allocation on mental health services. I haven't been able to get clarification on the breakdown of a difference between that spend and what is actually spent on the Isle of Wight. We could probably make some assumptions there, but if you give us the opportunity to perhaps have a look at that, I probably would suggest that Eugene might want to come in on this point, but that's the sort of number that we're looking at, and that 9.1% will be coming into our trust in the main.
Thank you, Nikki. And any questions from the members? If you have your experience in that, please feel free to jump in. Thank you.
Thank you. So happy to maybe come in. I think that the 9.1% is an aggregate position. So that talks about the totality of the 5.7 billion that the Hampshire and Isle of Wight ICB has at its disposal. And whilst that element comes into our trust as the mental health provider and community provider within the NHS, there are also other providers that are within outside statutory services that are providing mental health support. In actual fact, the drive and direction, both nationally and locally, is to try and create a more of an even keel around that, so that we've got proportionate statutory provision and voluntary sector enhancement, local grassroots, people with lived experience, which don't necessarily need to be within the gift or managed or employed by a secondary mental health service provider and provider of community services. So I think that 9.1% is just the element that comes into the organisation. There are other elements that relate to mental health within that whole picture.
Okay, carry on, Lucy.
I was just going to say, I think it's probably fair to say with some kind of estates environment, we probably weren't in a great place when we first joined the new organisation. We were part of an integrated trust that really had acute specialism in the estates, and we started working before we joined with Solent Trust, as it was, and worked with their estates team. They helped us design the 136 suite, and they helped us in the early days of the new Newport Health and Wellbeing Centre. But I would say, since being currently at the moment, there are improvements. That anti-ligature work is taking place. They're slowly working through. They have to close a bedroom and do the work. So that is happening. And we've had improvements to our seclusion suite to improve visibility in there. So it feels like we are playing catch up, and the estates team has been really flexible and really invested. And it's been really Yeah, really reassuring and actually really good fun to work with them because they know what we need and what our patients need. So I think you're right to say we probably weren't where we should be, but it does feel like that is beginning to change.
Thank you for that. And just as a supplementary, I know we spoke yesterday, Nikki, at the Newport Health Wellbeing Centre, which is a fantastic facility, and I encourage the committee to go down there and have a look. But it's still, even if it's 9.1%, we're still lower than the national average of what we're supposed to be getting for funding. So what is it that the new trust that's been created is doing to ensure that we have that equitable distribution of funds from the NHS, which could be tens of millions of pounds, which effectively could have helped you out with the state situation initially for that CQC report. So what is it that you're doing currently to get that back up to the national average in terms of funding?
So again, happy to come in on that. So it's actually quite opportune because the round of future commissioning, so the commissioning tends to be on an annual cycle. We are looking at extending that into sort of more 3 to 5 year plans longer term. But the commissioning intentions, which is essentially the script of services that we agree between us and the ICB in partnership with local residents and a sort of grassroots feedback around the gaps in service provision. So where we've got gaps, where we've got cost pressures, where we've got insufficient resourcing, also where we're bloated, where we've got too much resource. And I suppose the sort of point here is that the organisation itself is still fairly early days from October 24 into where we are now, but we are seeing opportunities to shift resources to maximise where it needs to be and be more efficient where we've got resource in excess of what's required. So part of that is making sure in-house that we're using that effectively. We've also got within the 5.7 billion a very helpful workshop that we had, myself and Susie were at, with ICB colleagues alongside all of the acute providers and health providers in the system to look at how that's going to be allocated out. And so there is an opportunity to influence that significantly, especially where there are gaps, issues around care and delivery, or the environmental issues that you've raised.
Thank you. David, just stick your hand up first. If you wouldn't mind, just the rest of the committees, check your hands up and I'll stick your names down if you've got questions to ask. Thank you very much.
Yeah, thank you, Chair. I've got 3 questions, but I'll only ask 2 and I'll try and combine them into 1, if I may. Now, I'm assuming, like nearly every other service, there is increased pressure on your delivery and how many people need your services. My worry is how, and the improvement is noted and well done, congratulations, but how are we going to continue to improve if the resource stays the same, but the requirement grows? And how is that, how are we going to measure that improvement? Or do you understand what I'm trying to say here? That I'm a little worried that, yes, you're making great progress at the moment, but I foresee perhaps a plateau where you haven't got enough to do anymore.
I think one of the main ways we're trying to kind of cover that capacity gap is by working in much more joined up ways with our partners. So if I give an example, in mental health, we have in primary care, there was investment and they have something called mental health access coordinators. They take new calls or e-consults, triage and help get people onto the right pathway. Now we have an access to intervention service that does that for secondary care. It makes no sense to have 2 separate entry points. We need to bring that together and the work that happens there to be shared straight into ours. So trying to reduce that duplication, and this is part of the neighbourhood working, is trying to work all together. So we take away that repetition, the duplication. If someone's going out to see someone, they can do this function as well. So there's that element, but you're right in that it's hard to, you have to have really good kind of modelling and planning to say this is where the growth was going to go, and this is with our changes what we've made, so that you don't you can still see, yes, you might not, it might be a sudden, wow, this is brilliant, whatever this has gone right down. We have to be really careful with our modelling and trajectories to show that. We do have some excellent business intelligence colleagues who help us with that.
Can I just come in just to supplement that, if that's okay? I guess that maybe the other element to the background is that whilst the legacy organisations came together to form the new trust in October 2024, there was a significant streamlining of the management and leadership arrangements within that organisation to make them the most efficient. And those resources, we were really clear, and we still are, that we protect the front line. So those clinical services are paramount because they are the people that are delivering the care in people's own homes when they need it at the right time. And we have got a vacancy factor, and I think Lucy's talked about that, which we're trying to address to get to provide greater resilience within the island, because resilience is an issue on the island. It really is. So I think our line is that we need to be the resources. There are tranches of money that are being released, and anyone who's seen the recent media around mental health can see that there are sources of both capital and revenue funding which are being released to support urgent and emergency care within mental health crisis, mental health EDs. All of these things do come with real money, and we're looking at, as Lucy has described, how we might utilise that across the organisation. But of paramount really is that we have to protect the front line. We have to be more efficient, and we can be more efficient with the resources that we've got in order to do that.
Yeah. Yeah, and the other thing we do is we have what we call a quality impact assessment process. So if the divisions are wanting to make savings and change resources, they have to actually go through that independent review process, which is chaired by myself and the CMO. So they actually have to talk about how they're protecting patients. And that's another check and balance, because we also share your concerns.
Thank you, David. Councillor Garrett.
Thank you, Chair. Thank you to those who presented. That was very helpful. I want to try to combine two questions. One is around governance, and issues around governance were throughout your presentation, with a very specific thing that's in your report about the feasibility of developing a dedicated urgent and emergency care hub, which, if you ask me, and from what I understand, is really needed to reduce the pressures on other parts of the NHS who are having to pick up work and they are already under great strain. So as we know, almost all of the NHS is under great strain. So could you take me through the pathway of governance on something like that? So I think you've got a board meeting next week, is that right? So I was looking at your papers for that, and I couldn't see mention of that particular issue. How can we be assured? Where do we go amongst your 7 or 8 committees, which I don't think the minutes are reported online, or I didn't see them there? How can we seek assurance that you, as from the governance perspective, are ensuring that things are actually being delivered? And if you could, what exactly are you looking for in terms of a feasibility? If a service is needed, what does feasibility mean here? So the governance level, what's your pathway of taking something through that, so that we, the public, can look at minutes and see that you're doing it? And in this case specifically, what does feasibility mean?
Again, I'll make a start on that. Thank you. Great question. Really, really important. And governance is at the heart of what myself and Susie live for, frankly. It's what keeps us safe. So just in terms of the board pack, which is on Tuesday of next week, you're correct. We do have reports from each of the committees, which are non-executive led committees that have executive attendance within them. And one of the Finance and Performance Committee, which met recently, will be reporting into the board around something which we're calling the Single Accountability Framework, or the SAF. Which is a mechanism we've brought into the organisation to provide a lens of governance through 4 key domains: finance, quality, performance, and workforce. And they are led by each of those 4 domains is led by an executive chair. I'm the chair for performance. Susie chairs quality, and we've got colleagues that chair the finance as well as the workforce. There are a set of metrics. We've got lots of things that we're held to account for, far too many to discuss in this forum this evening. But we've distilled that down into the key nuggets, key areas that those chairs believe are the most important in terms of those 4 domains. They amount to around about 40 plus. So each of the divisions is measured and scored and regulated against those metrics. We can then get a sense of where the pinch points are around, other issues across the board, or is there an issue here in terms of people and workforce, a vacancy factor and resources, or is there something around money here that there's an underinvestment, or is there something around the performance metrics that we both report inside and outside the organisation and are visible for members of the public to view? It's in the public domain. So that's our route through to governance. It is fairly embryonic. I, along myself with the executive colleagues, have been leading on that process, and I think we feel that it's an effective tool. It's a distillation of lots of things down into kind of key measures that people can get their head around and work to, and it provides us with a really rapid assessment because they're reviewed every quarter around the performance of each division within those domains.
And the quality is monthly, so we review all those recommendations. We're going to all those metrics monthly with the divisions.
Do you have a supplementary?
On my specifics of what are you actually looking for in this feasibility study? What is it? The feasibility of finance, feasibility of estate, feasibility of human resource, those sorts of things.
I'll do my best to answer that, Councillor Garrett. I mean, but the urgent emergency mental health hub we're right at the concept stage. So we've spent some time with our estates colleagues looking at the estate alongside looking at the demand and the need and the impact that we're seeing on, as you rightly said, other partners. So we're looking at whether you call it a 3-legged, 4-legged stool to actually assess what we actually need longer term. We think we're at a point where we think some estate changes along with redesign of our workforce and how we work our urgent and emergency care pathway will actually enable us to make the improvements that we expect. I know Eugene wants to probably come in on this point, but just say it's really early stage. But we think it's really important to engage partners in that conversation to actually almost do a sort of consultation in a way with partners to say, actually, we're doing this. What do you think? How could that look? And with, of course, staff to shape that, whatever that future is. Sorry, Eugene, do you want to come in?
No. Thanks, Nikki. Again, just to sort of maybe support that, there is a tranche of national money, 135 million over 2 years to support mental health emergency departments, and that's governed by NHS England. And there is an application and criteria that's quite rigid and strict around that. And one of those is that the testing of feasibility is actually done by NHSE. So the proposal and the proposition is put forward by an organisation or a provider. It's then tested in terms of feasibility with NHSE. That's one tranche of money. We've also got opportunity within the current mix and economy that we've got in the organisation to look at how we might reconfigure services without having to draw down that tranche of money, because there's the 10-year plan, which people will be familiar with. The NHS 10-year plan talks about 50% of EDs in the next sort of 3 to 5 years will have a mental health ED department alongside them. So that's the national direction of travel. We need to make sure, and we know that people get a really raw deal in all of our acute hospital settings who are in a mental health crisis. That's not unique to Hampshire and Isle of Wight, but we are guilty of that. The whole country is guilty of that, which is why this has come in. The length of stay, the waits for people with mental health conditions is disproportionately higher for people with mental health conditions. Far greater people spend 12 hours, 24 hours languishing and waiting in A&E, which is a completely inappropriate environment for someone who's in a mental health crisis. So we are looking at both the national pot of money to draw that down, and the feasibility is great. Also looking at what we might be able to do within our own estate to configure and create a solution which is better than the default, which is waiting A&E for hours on end. It's really not good enough, and we accept that.
Thank you. Okay, so we're at 6 o'clock now. It's been an hour we've sat here. I've drunk a lot of water. But when we'll do a short recess, 5 minutes, come back and you can ask your question if that's okay, Councillor Love. Or have you got something that's more specific to what's been said there?
I do want to ask my question, but
This isn't the end of the questioning phase. It's just that it's 6 o'clock and people have been sat here for an hour. I really want a really robust hydration break. And we'll reconvene in 5 minutes. Thank you very much. Thank you very much. Is everyone back in and we're all back online? Excellent. Councillor Love, did you want to ask your question, please?
Thank you, Chair. Let's just move that over there. I'm a fairly sort of plain person, really. And what we haven't really talked about is the customer experience, really. And I know we do lots of stuff generally about how did you experience this? In fact, actually, I got asked the question, not about mental health, but how did they experience it? And I was sat in the waiting room waiting to be seen, and they hadn't experienced anything at that particular point. I think the point is I measure things in terms of improvement by what my constituents tell me. And what they've been telling me over the last years, and I've been here 9 years, is that things are getting worse, not better. So I'm waiting for them to start telling me things are improving, because that's really what it's about, the customer experience. And I do thank you for your reports, by the way, that, you know, they're really illuminating in terms of what your organisation is experiencing and how you're trying to work on things. But at the end of the day, it's about what the customer experiences. And so when I say customer, it's not quite in that terms, is it? Yeah, money is always going to be a problem, but it's about how the service adapts and moves forward. And you've given us lots of nudges. What I really want to hear, though, is I'd like to really hear, Chair, from Health Watch, because Health Watch to me is a really critical part of this in terms of looking at the before and after events of what people experience. And I have to say to you that even while 35 weeks, did you say? I'm trying to get it down to, you know, if you've got a mental health crisis, 35 weeks is a very, very long time, even though it's better than what it was before. And whilst we've got systems in place, we talk about the person, but it's about more than the person. It's about the impact on the family, community, and everything else around it. So I would like to hear some reassurances that actually, you know, whilst you're aiming for 35, that actually that needs to be reduced to as little as possible. And I understand your problems with recruitment, etc. It's always a high cost. I did work with the NHS for quite a long time, so I understand a lot about that. But the point is, for me, is it's really about understanding. And so you talked about feasibility earlier. I want to hear and receive more things from the lived experience and the pre-experience, because, you know, what is the experience of those people who are having to wait for 35 weeks up to that point? Because that then should inform how the service develops and changes to meet that need. And I know you've talked about, you know, you have systems, but to me, you know, anyway, I've said enough about that. That's what. So I'd really like to hear from Health Watch, please.
I have spoke to Joanna, and we'll have a question afterwards, but I'll move on to the rest of the committee. So we've got, the next person was Councillor Richardson. Thank you.
Thank you. It's kind of similar to Councillor Love's question, really. I see you've been going through a lot of organisational change there, and there's things that it sounds like it's going in the right direction. But I guess my question is, like, how did it get so bad that those figures are really awful? That report was quite damning. And although it sounds like you're doing really good things, really looking at that direction is brilliant. But getting to those figures, how can you, yeah, it was really like, how can we promise people that you're going to get to those figures? Because how could you not then, and since this report, in the last 6 months, you've been able to do it, why couldn't you do it then? Why was it so bad? Why couldn't you make these changes then that you can now? Is it funding, you know, staff changes, you know, these things that, yeah, because the lived experience out there is really poor, and people, if they've got an issue, are finding that there's nowhere to turn. So it would be good to know. Thank you.
I would say demand is growing, and we can see that in lots of services. And I think previously there's been lots of incremental changes, trying to fix things, trying to fix parts of the system, and actually we've run out of road with that. The demand is too great. the money available to do it has got smaller. So we have to change things much more fundamentally, which is why we keep mentioning transformation, because just kind of tinkering, improving isn't going to make the difference. And I think what is helping to make the difference is, rather than us being one mental health division, we are part of a larger mental health organisation with that expertise. So we're trying to do wholesale change that is based on best practice. There's a louder voice. We do absolutely seek input from our service users. We get an annual survey and feedback from community mental health services. And I totally accept that for people, especially if you're in crisis, that experience can be poor. And there's been a lot of work around a big programme of change between primary care and secondary care called No Wrong Door. We've made good improvements, but I know it doesn't feel like one door. It still feels confusing. So I think it's that shift from incremental changes to changing the pathway really fundamentally, and that's what we're trying to do at the moment.
Just as maybe supplementary to that very briefly, as Lucy mentioned, the CMHT survey, which is direct feedback from service users who have experienced our services, so the customer, so to speak. We are in the top flight nationally for that feedback. So I'm not diminishing the feedback that you're receiving from constituents and people within the island, but overall, in terms of the organisation, the feedback from people that are recipients of the service and engaging with our community mental health team is in and amongst the best in the country. So that was, so I think we were at the top flight, literally a year or so ago. So there's obviously always more work to be done, and waiting times is a real problem. If you can't access the services, they can be as good as you want them to be. You can't get into them. Kind of what's the point? So we do need to work really hard to address those access points, people getting the service when they need it, right place, right time, right person. That's what we need to get to.
I just
Councillor Blake's been waiting. You can follow up after it in a second. Councillor Blake.
Thank you, Chair. A lot of my colleagues have raised issues I'd have wanted to speak about, so I'll move on to something else. But I think the real question of all of this is, are these plans actually going to give a better patient care, or are they just simply new governance systems? I mean, that's, we keep coming out and saying things are bad, we're changing this next year. Things are bad, we're changing this, and it's that. I've said it in this committee before, but perception is reality for a lot of people. But I think just using my own A&E experiences in the last couple of years and others of my residents, I think knowledge it soothes a lot of people. I think it did help when there's that board outside that says your A&E is going to be, even if it's 24 hours, you know what it's going to be. Yeah, you don't know. Am I going to be in here for the next 3 days, or am I? The people need to know. I would like to know how often that's reviewed at that time, because it does seem to be too dynamic. It seems to change almost per week, and I'm sure it's a lot more dynamic than the board says. But I think also, just when you're in that waiting room, there's a few sort of aggravating factors that cause some patients obviously to get heightened emotions, and I think that then adds to the more stress to the whole room. First of all, the seats in there are diabolically uncomfortable. There's no mobile signal. Yeah, things like that make the time pass so much slower. Equally, I know there's an issue at the moment with the prison, because they've got their RHU is rammed. It's basically used as extra beds, and they've got a few people in there that have worked out if they shove something up there, what should we call it? They get a day out in the hospital. What's annoying for the people in the waiting room is A, that they're showing space to that person. B, that person is being effectively hurried through, or the perception is they're being hurried through the system. They're getting into their obs, back into the room. They've got 3 prison officers with them, taking up half the waiting room. They then seem to be getting seen quicker than everyone else there and ushered out. Now, that's one thing, but other patients in that room think, well, why aren't I getting seen that quickly? And then equally, why do I sit next to this bloke for so long? So, I mean, it's little things like that. I think actually in the A&E waiting room could soothe a lot of issues. Ease nurses having to come out, and other staff there to literally respond to it. When I've been there recently, to a bloke kicking and screaming on the floor because he hadn't been seen for what he said had been hours. He came in after me, as it happens. But it's that kind of thing that I think would give the experience a much softer kick. And I think that might help. But that's happy.
If I start, thank you very much for the feedback, Councillor Blake. Okay, I'm speaking quietly. Don't know what's going on. Thank you very much for the feedback. We will pass that on to the Isle of Wight Trust, who's responsible for the emergency department. But as a trust ourselves, with our mental health patients going into that environment, we're very conscious about the amount of time and loud, bright lights, all the things that you perhaps wouldn't want when you're in crisis. So we are working very closely with them on what we can do. One, to move them to the most appropriate place to review them and care for them and treat them. But we've also asked our lived experience colleagues to actually spend some time within the emergency department and to talk to people about their experience, so we can understand what is important, like your feedback, and what matters to them and what their experience is. So we're going to bring that back in, not only for us to work on as a trust, but also to share with the Isle of Wight Trust as well, to see what we can do differently. It is a very big waiting area, absolutely acknowledge that. There's no sort of separation, there's not necessarily some quieter areas, so we would definitely feed that back. I don't know if anybody else wants to come in. As just my experience of that environment as well.
Nice. It's another supplementary, because there is extended waiting periods as well. You do get the consultants change over, and then you get one going down one line of diagnosis, another next one coming and going, no, I don't think that's right, and that creates more tension as well in the room. But it's another point. But yeah.
So Councillor Love first, then Councillor Bauer, Councillor Adam, and then Councillor Llewellyn. Thank you.
Thank you, Chair. I'm just really mindful of time. We've got a huge agenda, but just to very quickly. Once people get into treatment through the emergency access, that's a good experience, I'm told by customers. My problem isn't that. My problem is saying 95% of people, in terms of mental health, that's where I'm giving good feedback. However, we've got a CQC report that says requires improvement. Can you see the contradictions straight away? So that's why I'm saying it's what the people say that matters. And I'm saying I don't know if I can trust that information, because it seems to me that we've got a complete two-end contradiction there. So that needs to be fixed. Something needs to be fixed there. So it's about the before, you actually waiting to get in, and afterwards. And I still say that it's too long. It's too long. People, when you've got mental health issues, it's too long. And I don't have any solutions, and I wish I did, because I feel for you in that. Okay, but I'm still saying that. But I still think, shut up. That's my point.
So who do I say?
Can I respond to?
Please do.
I just wanted to say, I just wanted to clarify with that 35-week wait, that is just for specialist clinical psychology. So that is, if people are in crisis and need seeing sooner, they will be seen much sooner than that. They will be seen by the community mental health team in general sooner than that. That is if someone's waiting for a specific psychological treatment, which I agree it's too long, but I didn't want anyone to walk away thinking you wait 35 weeks for a community response.
Thank you for that. Councillor Bauer.
Sorry, just wonder if I could maybe bring in some data just to help inform that. So within the region, the South East region, we are one of 6 mental health providers, and we have regulated activity around 12-hour and 24-hour waits of people with mental health conditions in A&E, and a sort of performance league table around that. We also have the crisis home treatment team response to referrals within 24 hours. So how many people we've seen face to face within 24 hours of that referral cohort. In terms of the CRHT 24-hour cohort, we are the top performer in the South East region of all those 6 mental health providers. And with regard to 12-hour and 24-hour delays, whilst they should be 0, and we accept that, we're second and third in those rankings. So there's more work to be done, but I think it might be helpful just to get a context of the kind of create the landscape outside of Hampshire and Isle of Wight.
Thank you, Eugene. Councillor Bauer.
Yeah, I'd just like to echo some of the things that Councillor Love has mentioned about the long delays for mental health treatment. I've heard a lot tonight about difficulties recruiting staff, attracting people to the island. I just wonder whether there's an opportunity perhaps to deliver the treatment in a different way, or are we just going to deliver it in the same way we've always done it? Are there opportunities for us to perhaps look at, instead of bringing people over, they can have a screen or a Teams meeting or something? Are you looking at sort of delivering stuff differently to reduce wait times for initial contact?
Yeah, and we do that. I think during COVID, we learnt a lot about how to do that, and we do offer quite a few remote kind of online sessions with people. We do have doctors, we do have mental health practitioners, we have psychologists offering that. It doesn't suit everybody, but that option is there, and is something that we quite often review and try. And I think the patients want it. We've got to get our staff to be offering that as default if their patients want that. So we do quite a lot of monitoring of people telling us what they actually want. Thank you.
Thank you, Lucy. Anything to add to Councillor Bauer? Anything to add there, Councillor Bauer? You finished with that question. Councillor Gordon, and then Councillor Llewellyn. I think that you're done. Councillor Allen, thank you.
Councillor Bauer has just covered what I was going to ask about technology, maybe being a way forward if we can't put people in place over here. It's been done by Councillor Bauer. Thank you.
Councillor Garrett, and then we'll go over to Joanne, and we'll wrap up on the questions. Thank you.
Thank you, Chair. There was discussion earlier about the freedom to speak cup or freedom to speak. It's really good that you have that sort of thing, and it's really important that you have the means of getting candid understanding of what it's like on the shop floor, so to speak. It's a terrible analogy. Two sides to that. How often does the board get down there for more than a meet and greet, but actually a proper lengthy observation and understanding? And second, how would the board satisfy itself that it had made changes based on responses through that program? So maybe you have an example of somebody put this forward and we made this change because of that. Because I think what I hear from the NHS is there is very much a top tier and a very different experience down here, which is delivering the hard work. And quite often people would say to me, I'm married to one of these people, not in your trust, by the way, so no interest to declare. But if they just came and talked to us, this is what we would tell them, and then things would be better. So do you have examples of where that program has worked in that way?
So Natalie, our Director of Quality and Professions, she keeps her Fridays clear, and she doesn't always get to do it, but she keeps that time to go and spend with teams. So she'll go out with the team. She went out with the crisis teams fairly recently. I spent a day in 7 Acres observing the ward rounds, and we've made some changes to that. So it does happen. We have to really try and protect it, and it is really hard to keep it in the diaries, but that is something that we do.
And we do the same as execs. So we do triangulate that. And in fact, Eugene and I have our CMO colleague, we have we receive feedback and then we make sure that we go out. So what we're trying to do is have 2 separate sessions. So we'll meet with staff and then we'll also meet with leaders so that the two groups can speak independently. So we're trying different things and different approaches because it's not all services are the same, but we do triangulate. So if there are concerns coming through, incidences or freedom to speak up, well, then we will make sure that we prioritize those services. And I personally try to get out at least once a week, more than just meet and greet, but obviously that's part of it too.
And can I just pick up the freedom to speak up
Yeah.
specifically? So that is reported formally into the board. So the Freedom to Speak Up champion has a report which covers the whole organisation, the number of contacts, the nature of the contacts, the thematics that arise, the actions that we need to take forward. It's a really, really important aspect of our work. It's a great feedback loop and mechanism. It does come into board.
Yeah. She also meets with the chair, she meets with myself. So we also have monthly sessions with our Speak Up Guardian lead as well, because she gives us good intelligence.
And any particular example where you can say, this, you said we did, is soften the phrase.
To say, I'm just thinking of we had some feedback through the route that somebody was struggling with mobility in one of our buildings, and we weren't quite sure why it hadn't come to us, but that has been picked up. The assessment's been done, changes have been made to the estate to allow the member of staff who's a wheelchair user to get around. And I think she just hadn't raised it because it probably seemed too difficult, too much money, but that is something that we picked up and acted on. Or I could give you quite a few, but I'd better stop. Yeah.
Thank you for that, Lucy. Has anyone got any other questions from the committee? Is everyone happy that we go over to Joanna from Health Watch? Joanna, please ask a question. Thank you.
So the staff.
You're not on speaker.
Sorry. Okay, thank you. So is that better? I wanted to commend the Trust on some of the things they've achieved so far, namely the reduction in the waiting times for dementia assessment from 19 weeks, and it was 88 weeks a year ago. And that's so key. Getting a dementia diagnosis means you can get access to support and medication, which probably otherwise isn't accessible without that diagnosis. So that's so important to people. Also, someone contacted us today to say that you were one of the only local trusts that provides information in an accessible format, large print letters, for which they were very grateful. And again, that's so important for people. I've got two questions, if that's okay. One is specifically around the secondary psychological therapy service. So the average wait is 35 weeks, but specifically, what is your target around that? And when do you hope to achieve it? The other is around the Freedom to Speak Up Guardian. So you're probably aware that Penny Dash did a review of patient safety services, which resulted in the National Guardian's Office closing on the 1st of July this year. And previously they were responsible for the Freedom to Speak Up process. That responsibility has now shifted to individual trusts. So I just wanted to ask you how you're going to ensure that that process remains effective and that staff still feel empowered to speak up, despite that change in kind of governance of that process.
I think I can answer the first bit because you know you've reflected, and thank you for your feedback, Joe, around improvements in waiting times. Obviously, that is really imperative for us, and we've got a number of green shoots where services are reducing their waiting times and people are waiting less time, but we're not where we would want to be. With regards to psychological therapies, our target is 26 weeks. We expect to get there by January. That's still a fair amount of time away, and then we will obviously continue to see how we can improve from there. But that is a target that's been set for us. So our plan is to deliver that. With regards to freedom to speak up guardians and the review, Eugene is going to come in on that one.
Yeah, no, thank you. I mean, great point around the independence of the Guardian. So the Freedom to Speak Up Guardian reports into the director of people within the organisation. So the people director, who has got an interest obviously in the trust's affairs, but isn't directly accountable for the delivery of those services. So that provides an opportunity for independence and impartiality around the information that's received in. It wouldn't be appropriate, for example, for the Guardian to report to me, because I'd be essentially marking my own homework around the services that I'm responsible for. So that provides that degree of independence. And I think that obviously it's early days, as you say, but that will provide, we hope, that impartiality and ability to differentiate the issues that are coming through the freedom to speak up route versus some conflict on occasions with the trust and where it wants to be. So I think that provides that for me.
Thanks. Are you happy with that answer? Lovely. So we then go we'll go on to the recommendation. No, I know it's not, because we'll do it together. But just give us a second and we'll go there. All right. So initially, we just need to acknowledge the report and the action plan, which something was supposed to be that you mentioned the action plan in here as well. Have you managed to get the action plan sorted out for us to be able to read, or something get over to us with your comprehensive action plan?
So we will be sending that, but we haven't completed it yet because we're consulting with our local staff. That we think is really, really important. We have submitted the CQC action plans to the CQC, but I think you want to hear about the local delivery plan and what that looks like. So if you could allow us to complete that, make sure we've got that signed off with staff, then of course we will send that over to you.
Thank you very much. So we acknowledge the CQC report findings. So the first one would be also for you to send over your action plan. To the committee, are there any other actions that you'd like to have put into the recommendations?
So in the recommendations, I've just taken a stab at this. I'm not saying this is particularly right, but my recommendation is for the NHS to implement the urgent repurposing of facilities to represent the island people's mental health and well-being, and to identify some timelines in which this is completed. So that's kind of my stab at that.
That's a really big recommendation.
Well, that's what we're here to do.
Yeah, absolutely.
So you might want to pick that apart, but nevertheless, there's no point in us being here if we're not.
No. I would suggest that in our next meeting, workflow meeting, is we discuss that and actually bring it as part of the agenda if you would like to. And then we can get a report on what it is that they're doing. So we can get some information and find out what's going on there first before we then start making recommendations from us.
I'm sorry, but that's what we're here to do. We're here to make recommendations now. That's what this panel does. And we can do that as well, but we're here to make recommendations.
But nobody knows anything about what you've just recommended, so it would be beneficial. Please, Laura, carry on.
Councillor Whelan, Kate and I have just had a quick chat, and given the extensiveness of the information you've heard today, we wonder whether committee members might like the opportunity to process what they've heard with a view to forming a recommendation. We'd be really happy to assist you with that at our next committee engagement meeting, so that a formal recommendation can be drafted by yourselves, having had the opportunity to digest the information and perhaps the action plan as well, and then could come back to your next committee as a separate item under scrutiny for you as a committee to approve.
Thank you, Laura. Okay, yeah, I'm happy to move to the next item. If everyone's happy with that recommendation, then we go from there. Can I have a show of hands for that recommendation, please? Abstentions and against. Thank you very much. That motion passed. Before you guys go, thank you so much for coming. I really appreciate your time and the information that you've given us, and we're really looking forward to, as a committee, to see what the action plan is. And so I'm assuming that the Isle of Wight public, our residents, are looking forward to seeing that action plan too, and seeing actual changes and improvements as the committee have brought up with regards to what it is that we need to do with that within that action plan. So thank you very much. If you need to go, you may leave. Thank you so much. Okay, the next item on the agenda is the Director of Public Health annual report. Thank you, Kate.
Thank you, Councillor Whelan. Committee, I will keep the introduction brief because the report has been circulated. As a reminder, one of the statutory duties of the Director of Public Health is to publish an annual report on the health of the local population. The reports are on different topics each year, and this is the first report under the new public health leadership specifically focused on the Isle of Wight. So I think it's a really good moment for us. The report has been to the Health and Wellbeing Board as per the statutory requirements for reporting. It's coming to committee really threefold. Firstly, to assure and inform you that one of those statutory responsibilities has been delivered. And secondly, for the content and any questions you may want to raise and to be noted here as well. And thirdly, to share with committee that, of course, as a Adult Social Care Public Health Housing Needs Committee, the service elements fall here. Across the council, every service committee has an influence on the health and wellbeing of our residents, including for our working age population. So I will be taking the report to the other committees with their chair's agreement for further discussion.
Thank you. I'll put it to the committee for questions. Councillor Garrett, please do.
First, it is incredibly welcome to have a first report, which is island focused, because we have an island person, an island focused to your role, and that's great. Tons of data in here, but the thing I picked out particularly was your commentary about economic inactivity, and that contributes to poor physical health and poor mental health as well. So I think it's actually what you're reflecting back to us is an important kind of piece of the data that we'll need to be using when we develop the corporate plan to ensure that all of the work of the council works towards having an economy that's stronger, that there are more secure jobs that better pay, that lead to people being able to improve their physical health in some way or another, and to some extent relieve their mental health because of the anxieties that comes from being out of work or being challenged in terms of what Prime Minister now talks about rightly about just the cost of living. So I think, in a sense, it's the question that my question to you is, how are you going to make sure this feeds through every aspect of the council's work where it can do so, and hopefully we'll continue something I championed 5 years ago to ensure that addressing poverty, addressing economic inequity and inequalities remains an overarching theme of this council's work.
Thank you, Councillor Garrett. There's a lot in there, so I'll try and break it down into three little responses. The first thing is, I appreciate it. It's good to have an island-focused Director of Public Health now. We're at that stage. But to recognise the work of the team and putting together a lot of the data and a lot of the case studies from across the island as well. So a big thank you to Nicola, to Emma Lincoln and the team, and really recognising that collective effort. Second point around work and health. We do, on the island, we have healthy life expectancy that's below the England average and the South East average. So for men and women, it's around 59 years, which does fall in the working years for people. And we know in our island residents, we have a particularly high level of economic inactivity that's related to ill health. So there is absolutely a link between the health of our residents and our economic growth and prosperity. I think the other side of that link that I'd highlight is the link between our economic prosperity and the direct influence on health and well-being of our residents too. So that wonderful virtuous cycle that, as you say, if we get that growth and prosperity and development progressing through the corporate plan and wider partnership work, we can expect that positive feedback loop to really pay dividends for health as well. What I hope in terms of the report is that it provides some useful information for everyone through all influencing routes to be able to really support that agenda to move forwards. Recognising those building blocks of health are important for our residents, and of course the political leadership, the local officer leadership, the partnership work that we do being key there as well. And I'd include our wider NHS partners within that too. In terms of specifics, the report does pick up some specific recommendation areas, particularly making sure that we get the most out of that work and health agenda. And we've got the Get Solent Working Plan strategy, we've got the local growth and prosperity plan. So really being able to translate those into good outcomes for our residents. And personally, I see the public health role in that being one around providing some of the data and intelligence, but also supporting the links with wider partners. So for that growth and economic development piece, particularly the links with primary care, we've supported there too.
Did you have a follow-up on
One thing I would note that a new development, we now have a combined county authority. We may or may not have a mayor next year or the year after, but actually that has been driven by the government's aim for economic growth and prosperity. So I imagine some of what you've got will be informing the new mayor when they're in place, but also the authority at the moment. Just a question: what counts as towards being in ill health? Because it seems a long period of time, and I'm just about 7 weeks minus a day away from being 60 now. So, and I take a daily pill for a decades-long condition. Does that count me as being in health, ill health, or not? Am I already in one of your statistics?
So I think in the report, there's two sets of data that's relevant. There's one around the number of long-term conditions people have, but when it comes to healthy life expectancy, that's based on self-reported health. So it's individuals reporting that they're in poor or very poor health on the island.
Thought you were a medical mystery, Andrew.
Thank you very much. I'll ask my question. I'll hand you over to you, Councillor Blake. Thank you. So just a quick one. So along the mental health route, as we've been going down this evening, often people lose purpose and meaning after loss, family loss, whether it is through a loss of a job. It kind of sets in motion a set of events that potentially could lead individuals to actually pull themselves out of the economic work, or out of the workplace. What is it that we're doing with regards to the prevention of that? How are we assisting people that the community with that?
I'm happy to make a start at the response. It's a very, it's a large topic for us to cover. And I think the one thing I would highlight here is that we, around partners, we all have the opportunity to be able to promote mental well-being and prevent mental ill health. In terms of that approach across the system, we have the, let me get the name right, Nicola, Mental Health Strategic Partnership, thank you, that Nicola, my colleague, chairs, that brings together partners to really look at that prevention and promotion plan around mental health.
Thank you very much. Councillor Blake.
Thank you, Chair. Obviously, the report sort of highlights sort of issues that we've got, like, and the headline being that our healthy age now is now down to, is it 58.7, if I remember correctly, in terms of the age at which we become unhealthy as such. Of course, the island has been for decades before now, it has been a centre of excellence in public health throughout the Victorian era. We were the world leaders in come here and fix yourself, but we seem to have gone to the other end of the spectrum where we're come here and have a poorer quality life, die sooner, and be iller during it. So we've shown the way previously. So I think I have residents come to me with, wouldn't it be good if we could do this? And I not a single example comes to my head immediately, but obviously we have consultations when we have things like development of public health strategies and things like that. But that obviously is few and far between in terms of the public who don't know anything about it coming up until all of a sudden they may or may not see a press release saying, oh, there's a consultation on. Is there a possibility to have like a constant portal, just kind of like an ideas box? For instance, there was a couple of personal trainers that wanted to do some outdoor exercise and stuff like that, and there was some limitations of being able to on council land, for instance. But it's kind of that, put that idea in and then see if it can then feed through the council system, see if it can be actioned and stuff like that to improve our public health. Because as it's been mentioned, it's so key into so many things, and so many things are so key into it. And ultimately, if we're going to cut down on our adult social care ballooning costs, a lot of that can be done through a better general public health.
We are very well timed in having some of these discussions at the moment, because as a health and wellbeing board, which I know Councillor Whelan sits on, along with other service committee chairs and is chaired by the leader of the council, we are about to refresh the health and wellbeing strategy. What the board have agreed at the last meeting was to do that in a way that really focuses on a lot of engagement. So drawing together the learning we've had so far, remembering we've had an awful lot of conversations with our residents on the island about health and wellbeing, but doing some very focused and targeted work to add to that, to make sure that we are priority setting and learning as we go. In terms of feedback and ongoing engagement as a service, I'm very happy to I think have some discussion around how we can do that and what might be an option in that space. I think it will need a bit of thought to make sure it's useful and helpful with residents. But I think it's a good point for that conversation. And I know we get considerable feedback and ideas coming through our commissioned services, remembering we, as a public health directorate, we are a small part of the prevention budget on the island. So we get some out through our commissioned services, and a huge amount more information coming through our elected members and the very regular suggestions and queries that come through from yourselves too.
If I just just to add to that point as well, so particularly around mental health, my colleague Sharon, who leads on mental health, one of the biggest things we do is we run the mental health network, so Alliance, Mental Health Alliance, where we talk to voluntary sector, we talk to a wide range of parts, including Joe, and that also sources a lot of really useful feedback and really useful information brought into the team. So though it's not direct from us to residents, I think it's maintaining all of those different sources of interface, particularly with the voluntary sector and the Mental Health Alliance.
Thank you, Nicola. Did you want a supplementary? We've got Councillor Christensen. I think we were out of questions on this one afterwards. So, Councillor Christensen, please.
Thank you. It was a really good report, Kate. Thank you. And is this going to be useful for making our case for why we need extra funding on the island? I mean, every time we see that chart you do about the demographic on the islands, and it should look like a triangle, but it doesn't, and it's getting wider at the top. Is this going to be useful, having our own focus and having you and having this, can it be used to make our case really, because we have got these differences, and, you look at the national average and we're way off, and these bigger issues we've got with the health. So, can it help, please?
Yes, I hope it is already helping. And I would just highlight this report is one slice of local information, and just reminding committee and other partners that we have the joint strategic needs assessment with a huge amount of data and intelligence about the island's needs, and some very clear messaging coming through that in terms of our patterns of deprivation, inequalities we see within the island, but also the inequalities we see when we compare ourselves with some other areas in the country or our nearing neighbours.
Thank you, Kate. So we'll go on to the recommendation then.
Just briefly.
Okay, thank
So
you.
sorry, Chair. You actually touched on what I was going to talk about, which was inequalities. It's a great report, and thank you very much. I understand it is the first one. It's the first one for the island for a long time, specific. Inequalities. I just think my appeal might be to try and see if we can build on that next year to deep dive into those inequalities a bit more, so that we can try and put specific recommendations to specific inequalities, surely. Because poverty, you know, is very clear. There's a theme throughout, isn't there? Has already been brought out about poverty, deprivation, etc. And it's a great report that sweeps across the whole thing. But it needs to be backed up, as you've already said, within your specific reports. What I'd really like to hear is about how we're doing with drug and alcohol prevention, intervention, sexual health services, specific things about demographics of the island, ageing populations, LGBTQ, etc. Just a tiny bit more. That may well be within your large context, but I'd just kind of like to just try and capture that, because that seems to be, as you've already stated, many inequalities and many ill health, is preventable. So therefore, what would be your three things that you would pick out, the top three things that you would pick out to do, besides smoking? So I don't, because smoking always is, I want to know what the others are. Three.
Councillor Love, that's the age-old impossible question is. I think I would probably take us to recognising, I mean, the report has, I think, 4 or 5 recommendations, very focused for our working age population, as it should be for the scope there. I would draw us to the fact that more of our health and well-being is determined by the environments and conditions in which we live. So those social and economic and environmental conditions being absolutely key for our health and well-being needs. So I think that would be focus 1. The second area that you've touched on is around those behaviours that can impact on our health and well-being. So even small changes can make a big difference. Tobacco is the single biggest cause of inequalities, but also ill health, but also our diet, physical activity. And then I think thirdly, recognising the 20% of our health that is determined by health services. Health scrutiny often focuses on that element. And I think that's really important for the treatment services. I'd suggest also remembering the importance of attending screening appointments, vaccination, access to those preventative services that we know can have an improvement on outcomes and reduce inequalities. So I'd have it at that level, Councillor Love.
Thank you very much, and thank you for that question, Councillor. So we are seeking a proposer and a seconder for this recommendation, please, that the Director of Public Health annual report be noted, and that the intent to take this report to all other service committees to discuss the implications across council business be noted. Could I get a proposer, please, Councillor, and a seconder, please, Councillor Richardson. Can I have a show of hands for, please? Against? Abstentions? Thank you, sir. Unanimous. Okay, next item on the agenda is public health nursing. That are pages 75 to 86 for those guys that have got their hands up. I'll hand over to who's. Okay, thank you very much.
Thank you, Chair. I feel like I'm on a roll, but we'll keep it quick again. I just want to note we've got Eleanor Reid online, who is our Principal and Service Manager for Public Health, who picks up around children and young people and may come in around some items. So this paper is coming to committee for approval of retendering the contract and to request delegation of the contract award process to the Director of Public Health. I just want to highlight initially, there's no change to budgeted expenditure. So it's really coming to committee because of the size of the contract and that contract award therefore needs to come here rather than any change to financial position. Key points I'll draw out from the paper. It's public health grant funded service, delivers against key local authority outcomes and particularly supports our children and young people delivery through other parts of the council with an integrated model. As explained in the paper, we have a good quality service that's completed a programme of improvement, and I've highlighted in the paper the key areas where we see opportunity to move forwards. And we also have a good value service in terms of cost and impact. And I've also summarised and we've benchmarked in the paper a bit on that as well. So I'm very happy to take questions, but I was going to keep it as a brief introduction.
Thank you for that, Kate. Questions? Anybody got any questions? Councillor Llewellyn.
Quite a simple question, actually, at this stage. Are there any competitors we could go to for alternative tenders?
I can do a very recognising we don't have our legal and procurement team here. I'll do a very brief summary and response to that. Health services commissioned by the local authority are subject to different procurement laws, so we have options of going to open tender or taking other routes. And that will be part of the tender process, is deciding that and reaching the conclusion with our full legal and procurement advice to take us through.
Thank you very much. Any other questions? Councillor Love.
I always have lots of questions around health. Sorry about that, but I'll keep it very brief. Yeah, I mean, same issue that I had really earlier today is that it's a big contract. It's a lot of money, and we're trusting you to do that. However, I do have some ethical questions about that, and particularly when we say we might, if there's a risk that we might go outside into the private sector, etc. Those are ethical questions for tendering for services, and I think if that's the case, that needs to come back. I'm sorry that some of you don't agree with that, but if it's my head on the chopping block and all of the other councillors when it comes to accountability, then I want to know who it is that we're going out to because of ethical matters. I'm not trying to scrutinise you. I'm just saying I'm held accountable, as all of these other accountables, for who you choose to employ, that, and which seems rather bizarre in this day and age, but I like to know all the detail of that. So that's the only bit that I'm sort of saying here. People will, but I would like it to come back before we make that final decision. I know some of you are going to say no, but it's £2 million for the contract.
Thank you, Councillor Love. So, in my opinion, that this is just to start this process off. Am I incorrect in saying that?
No, it's asking for approval to award, delegate approval to award the contract, and approval that we will be retendering.
Okay, fine, thank you.
So will the next decision we see from that be a notice that we get an email saying a delegated decision has been made and this is the contract? So that's what we're dealing with. And what I think Councillor Love would like to see is some of that process and no before that. But we're saying, I think, just to be sure that we're saying we're going to leave that decision to you. And that's what we're deciding.
That is what I'm getting at, is that, you know, if we're talking about the Penn report and working together and being part of the process, we should be involved in that. And I know that some of you won't necessarily agree with that, but we should be, so that we give approval to go out and do the tendering as we did with the previous one, and then it comes back for us to have a discussion if necessary, as we did this morning in camera. But I'm just saying, it's £2 million. It might not be the way of some people's thinking, but it is my way of thinking, because otherwise I'm just giving a blank check. If I say yesterday to £2 million being spent on, well, for me, it's a bit like I walk into a supermarket. I
understand.
I buy a can of beans.
I understand where you're coming from.
But I don't know what make those can of beans are. That's the difference.
I understand your point. Okay, Councillor Llewellyn. Gordon, thank you.
Yeah, if I can ask Councillor Love a question. You said it 3 times now. Some of us won't agree. Do you want to explain what you're saying about that? You said you wanted to have it completely transparent, and then you look down here and say, oh, I know some of you won't agree. I don't understand what you mean.
Well, we all have different opinions. Some of you might not agree with what I've just said. That's fairly straightforward, isn't it? You can agree to disagree.
Okay, before we move on, Councillor Llewellyn, have you got a question to ask? Reference this.
I certainly have. Yeah, the reason I asked were if there were any competitors was that, you know, I am extremely concerned overall that we should be handing out a contract without a proper tendering process. Now, I'm sure you'll do it properly, but in the current financial situation, we are duty bound to analyse and look at every single contract that we award. Now, if we could save £50, then we should be looking to save that £50. And I am just concerned that we will just rubber stamp something and it will just happen. We won't have had a chance to examine it, to look at it, and to ask questions. Now, there is such a thing happening as the improvement board. Now, should this particular thing not go in front of the improvement board for consideration? I'm just asking the question. I'm not saying it should, but I need to know these things because as chair of PFR, my responsibility is to try and save money at this stage. And if we're just going to hand a contract out for, as Councillor Love says, £2 million, that's an awful big lump of our budget. That's all I've got to say.
Thank you. Kate, would you like to respond? Thank you.
Yeah, I'm very happy to. And the first suggestion is that it may be helpful to if it's helpful to have some councillor engagement. Obviously, when it comes to a procurement process, there are elements that I will look to my legal colleague to respond to. And there would also be discussions that would not happen in a public forum around some of that. And it may be helpful to pick that up through an informal engagement session in terms of next steps. I wonder if there's any procurement process input that would be helpful at this point.
Yeah, procurement falls slightly outside of my remit. What I can say to you is to echo the views of my colleagues is that there will be a proper procurement process that will be taken, which will evaluate things like the cost and to the council, and will assess that against a set criteria before a decision is made. And the proposal that you have isn't to award the contract; it's to tender it, and as part of the tendering process, to re-tender the contract. Yes, absolutely. I'm dealing with the first part first, Councillor Love. Yeah. So the first part is to go out. You can't award a contract before you've tendered it. So the first part is to go out to tender the contract and then to give delegated authority to the Director of Public Health to then award the contract following that tendering process, which will use an approved set of criteria through the Council's procurement team. And that is how that we dealt with. You've had the offer from the Director of Public Health to engage and to have some openness with members of this committee at points that they can do that with. So I'll leave my legal advice there. I'll pause for a moment just so I can give the chairman some advice on how we might move forward with this matter.
Before we,
I think it's worth councillors remembering that there are costs that are borne through doing things in a protracted way. Not only does it cost officer more time doing something like explaining what they're doing as they're doing it, but also if there's a elongated time taken to go through a tendering process, go through a procurement process, as someone that has issued invoices in the past, I will inflate the cost to someone I know is going to take up more of my time. And that is going to act negative. So I think we need to, our corporate image needs to remain as someone that's easy to deal with. I agree that we need to make sure we are doing things properly, but I think that's the sort of thing we set through our corporate plan and our strategies to tell officers, this is what we want out of our contracts. This is asking to delegate authority to the Director of Public Health. Therefore, I think that also delegates the responsibility. So in terms of that coming back onto councillors, I disagree because we have said, we have asked you to do things to the best of your ability. If that is then to reflect badly on the thing, we aren't the reflect, but I don't think that is the main issue here at all. So I think councillors ought to be aware of that.
Yeah, I think we've made this point. I think we're almost there. I just need to speak second and be with you.
on that.
Yeah, that's fine. Okay, so we'll go to, I need to seek a proposer and a second for the following recommendation, that the re-tendering of the contract be endorsed, that authority be delegated to the Director of Public Health to award a contract for 5 years with option to extend for a further 2 years at the sole discretion of council following completion of a full and compliant procurement process. Do I have a proposer? Councillor Garrett, thank you. I have a seconder. Councillor Critchson, thank you. Can I have a show of hands for, please? Can I have a show of hands for against, please? And any abstentions? Thank you. On to the next item on the agenda, that is item 8C, service performance and improvement for Q1 2026 to 2027. Thank you.
Good evening, councillors. This is a bit of a double act, so I'll leap in at this point in time because I've sat here quiet for a long time, which goes against the grain for me, and it just came a bit of a rest. The report before you looks at performance from a financial point of view, performance from a service delivery point of view, and risk across both adult social care and housing and public health. There are 2 key areas I just wanted to flag with you, and then happy to accept any questions. And obviously, Kate, I'm sure will do the same in relation to public health. From an adult social care point of view, it won't have escaped your notice that we are at the end of Q1 and there's an overspend of around £500,000 in adult social care already. That I can show you in the report is linked to directly providing care and support for people. If you go to the appendices, which sets out the numbers we're dealing with, you'll see that the number of people accessing care and support from the local authority has increased since this time last year. It's still increasing month on month, and it's those additional people coming into the service that are driving the spend against the budget. It's quantity of people rather than unit price. So to share that with you. The other area I just wanted to draw your attention to is in relation to performance, and the report at page 95 provides you with a summary of the people who are waiting for care and support or for other assessments. Taking them box by box, you've got a DOLS assessment box, 147 people waiting. In the average month, we receive between 75 and 95 assessments. So to have only 147 outstanding is pretty much business as usual and consuming our smoke. Some of you may recall a few years back, we were sat here talking about figures tipping around the 850 and 900 mark. So a marked difference in terms of where we are. There is a note of caution in relation to that number following a recent Supreme Court decision. The way in which deprivation of liberty safeguards are assessed and incorporated by the local authority has seen a fundamental shift. The systems and processes, the framework we've always worked with is no longer the framework that will be applied. The acid test has fallen by the wayside, and we're now required to look at deprivation of liberty in a different way. I won't go into further detail. There are multiple commentaries available nationally in terms of the impact that has for local people and specifically for people with disabilities or who have memory and cognition issues. The key point for us is we are still awaiting central government guidance as to what that new test looks like. What we will see in the period between now and that guidance becoming available and being implemented is an increase in people waiting for their DOLS assessments. We know we can't assess them under the old framework, but we don't have a new framework to work with yet. In that space, every single person is being risk assessed. We've got a RAG rating system in place to ensure that people who are higher priority are receiving more consistent support from the team. And we are ensuring that those people are waiting well is the phrase that we use. So mitigating any risks in relation to that area. We've discussed that with the local CQC inspection team who ultimately have oversight of that area. And they've confirmed that they're satisfied with the approach that the local authority is proposing to take. In terms of financial assessments, you'll see 46 people waiting, again, significantly less than this time last year. concerted effort in that regard. And for people who are receiving financial assessment under their Care Act, under our Care Act obligations, we're able to turn that around within 7 days now. So some really good work on the part of the team to ensure that people who do have to contribute towards their care and support are aware of what that contribution is likely to be at an early stage, so they can make informed decisions about their own care and support plans moving forward. 5C is the big number, occupational therapy, and at this time last year it was less than it is reported here. I've just double checked my data set and I can confirm that as of today that number has been reduced to 277 people. So the next time you see this report you'll see a very different number in that box. That's happened as a result of a concerted effort on the part of the team, but also from some external support that's been made available to us to help clear a waiting list. It was a waiting list we inherited when that service transferred back in-house. So it's been a firefight to ensure that we've been able to support all of those people in the most timely way possible. So some great work from the team there in terms of managing that. The annual review number of 248, you'll see, is about a third of where we were this time last year. And of those 248 annual reviews that are due, none of them are more than 3 months overdue, and all of them have been allocated to workers who will be picking them up and undertaking them. So that's pretty much our business as usual cycle now, to have around the 250 mark. I hope that provides you with some clarity in relation to some of the anomalies in the report, and I'm really happy to take any questions before handing over to Kate.
Thank you. Anyone from the committee? Councillor Blake, please.
Thank you. I think what would be really helpful is some of these percentages is to contextualise them with some numbers. For instance, I'm taking the percentage of opioid drug users who left drug treatment successfully who do not represent. That's 7.02%, which is green because it's higher than the, and that's probably a really good number. Now that the lowest number that could possibly be, assuming that half a person doesn't come off of opioid addiction, is 351. So does that mean then we have 5,000 opioid addicted people on the island? I mean, or is it more than that? Yeah, because that's the smallest number possible.
Councillor Blake, I'm unable to assist you. That's not my data set. My data set is all people and numbers. I don't do percentages. I'm sure Kate will be happy to assist.
That is a public health response and data set. I may need to come back to you with a written response, Councillor Blake, in terms of the specifics and the precision. I think my initial response would be, this is the first time this data has been reported in this way to committee. This aligns with the new local government outcomes framework. And I think there is work we can do to improve the benchmarking clarity, but also give some context around the scale of numbers too. I think that will really help an interpretation of the data, because it, particularly looking at some of our drug and alcohol data through the performance report, we benchmark well against a lot of the England average and a lot of other providers. We aren't sharing that with you for full understanding of the context.
Yeah, so I pick up that number as an example across the whole committee's report, because there's lots of numbers in here, and we don't know if that's just because is it because whole numbers, because in this particular committee we are dealing with people, is it because we've got 2 or 3 people and therefore 66% is 2 out of 3 people, which is quite good, or is it we've got 6,000 people and we're talking about 4,000 people? Things like that really help us in terms of, and I think also when we're going through things like our corporate plan development, we need to know what we're doing in terms of helping the people at the end of the day who we serve.
Thank you for that, Councillor. I 100% agree with that. It makes it easier for us to, you can see 7.2% and 0.2%, and then potentially 10,000 people is a different kind of way of looking at things. So thank you. Is that something we can look into doing potentially? Just makes it easier for us to understand, especially when we're cooking our brains at 29 degrees at 7:15 on a Thursday night. So has anyone else got any questions on that one? So Councillor Bauer, thank you. So Councillor Bauer, and then if you Did you have a question as well, Councillor Garrett? And I'll have you speak to afterwards. Thank you.
Thank you. I think I've discussed the issue of percentages before, and I concur with what Councillor Lake has said. There are, in the narratives below some of these graphs, there are numbers we can relate to the percentage. So I'm not going to enlarge on that anymore, but I just wanted to know, page 112, what is that about? Can someone explain it to me?
Councillor Bauer, could you tell me which section? And then Laura and I can...
H4. It's called something, percentage of duties owed where homelessness was prevented or relieved.
Councillor Barrett, it's a me question. I'm there. In terms of where we are, I've actually just sent an email to Dawn, who's online, and said we need to go back and look at H4 in the report because we're giving a percentage, and I know that councillors, based on Councillor Blake's comments, would rather know people. We don't owe everyone who approaches us a duty of homelessness. Where we do, 64% or the percentage in the report is the number of people who we've been able to support. What this graph gives you is information about the range of activities that the team are undertaking to support people who are facing homelessness. It's their attempt to address that homelessness with the landlords for the properties that they're already in, rather than see those people become homeless and then have to accommodate them through other routes. We will get better at how we're explaining that to you, and we will revisit H4 so that your next report contains a 100 people of 1,000 people report rather than a percentage.
Thank you, Councillor. Councillor Garrett. Oh, did you have a follow-up? Sorry, Councillor Barrett. Okay, Councillor Garrett. Thank you.
Thank you, Chair. First, I concur with what Councillor Blake was saying. We have spurious accuracy on the percentage points, and we don't have the what's called the denominators. If it's helpful, this is stuff I used to train on when I, in my past as an employee of the Royal Statistical Society, and that body actually has great advice on how to present data like this. I recognise it's not the director's data, and it is a criticism I've raised before that the whole presentation of these is not helpful to those of us who are trying to get an understanding of what's really happening here. So hopefully that will be reviewed. The director referred to the overspend at the moment of 500,000. As part of the budget process, there is an improvement board. I've tended to call it a transformation board. Is it up and running and involving the director? And what are its early conclusions?
Thank you, Councillor Garrett. The improvement board is scheduled to take place in its first meeting later this month. And yes, I definitely am involved. The information that was shared with councillors in our recent engagement session around the adult social care budget position will form the basis of the representations that we start to consider with the improvement board.
If I could just follow up on that, because there are two ways of looking at overspend. One is you are genuinely overspending, and you've got something wrong in that way, or the budget that was set was inadequate. I see a facial expression there on the director. I won't allude to it anymore, but it is something we as councillors have to be very aware of. And Chair, I was intimately involved in setting the budget last time around, that budgets that we set should meet the needs of the authority as far as we can do so, not just to make the numbers balance, which perhaps the improvement board will be able to get us to that position.
Councillor Garrett, you're absolutely correct. And I think it's a combination of both things. The allocation of adult social care is somewhat of a dark art in terms of we don't know who's going to need us. We don't know when they're going to need us, and we don't know what they're going to need. So in terms of predicting spend, it is quite a finely balanced scenario. When the local authority has such challenged financial difficulties, we end up in a territory where we look at real risk rather than perceived risk. And a lot of what my service provides is perceived risk when it comes to spend. The council in its last budget and several before had to cut its cloth according to the budget that was available to us. And as a result, a number of areas where we believe there may be pressures were areas that were unbudgeted for, as opposed to those areas where we knew that there would be. because we've seen such a substantial increase, around 25% of people coming to adult social care in the last financial year who didn't present to us before, and we had no idea they were coming. The budget simply is insufficient to meet those needs. I'm confident that the challenges we're seeing are around the numbers of people we're supporting, not the unit prices we're paying. We're benchmarking well in that space. I'm not confident that what we're seeing is the peak of those presentations. I believe our community will continue to need us in this area. And because of the way adult social care is determined, if you have an eligible need, the council has to meet it. That spend will continue to change. We've got some really robust mechanisms in place across the department to ensure that we're managing that spend as best we can. And historically, I have reviewed personally every single package of care that exceeds what we would expect somebody needing that type of care and support to need. We've shifted that position in this financial year, and now there's a structure where the really expensive ones come to me. My service directors have review and the service managers have review. It's been eye-opening because different people look at things in different ways. And what we've discovered is that actually there are different ways of approaching the same challenge, which is holding us more tightly to our structures and our frameworks than I'd anticipated. I'd thought as soon as I sort of let go of the reins a bit, I'd have to control people and help pull them back. That's not what we're seeing. So every single package of care is scrutinised, and it's scrutinised to ensure that the care and support we're providing is right to meet the need rather than the budget. So budget is almost secondary to determining what the eligible care and support need is and how we're going to meet it, but incredibly important nonetheless.
Thank you for that, Councillor Love. We will make this the last question for public health. From ACS, but you need to do your joints thing as well. So we'll go on to that. Did you want to? Yeah.
Nice, just very briefly. Staffing turnover, how are we doing, and where is that staffing coming from in terms of providing care and support? I really suppose it's an adult social care question. How are we doing in that? Because it's been a constant problem.
We, in terms of the Isle of Wight Council as an employer, currently have very few vacancies in our staffing in either direct care delivery or in social work. As I sit here today, I've got 2 agency workers in the department, both providing support in our approved mental health team. That's to cover essential qualified and uniquely qualified people who are unable to be at work due to maternity leave and sickness and those types of arrangements. So we're comfortable with where we are. I'm carrying, I believe, 5 social work vacancies in total at the minute. And across our direct care delivery, we're seeing turnover improved on where it was before, and our vacancies sitting at significantly lower numbers. I can't give you the specifics. It changes every day in a direct care profession. People come, people go, people move around a bit. So we're constantly managing those changes. As a commissioner of external private services in the marketplace at the moment, we carry anything between 15 and 17.5% in terms of vacancies. This is the trickiest time for us, with providers reporting that their staff are unavailable due to other arrangements, due to other need, predominantly school holidays and summer, or that people leave the care profession to take up higher paying roles in hospitality and in tourism. At this point in time, we believe there's somewhere in the region of 450 vacancies in social care delivery across the island, with a workforce of just over 3,500. That's quite a hefty chunk of people we need to recruit. I would anticipate at the end of summer that number reducing because people migrate back to those care roles, but it's a dynamic we're used to. Pre-COVID, the vacancy rate was sitting at around 20%, so there is an improvement post-COVID. But care continues to be a profession that's undervalued. And because of that, we see people more transient in terms of the support and their availability for employment.
And just ask tiny a little bit about how are we still dependent on care providers from the mainland providing day-to-day care, and they were agency or whatever they were.
No is the short answer to that. We've never been dependent on mainland providers delivering domiciliary care. We have 3 prime providers who have our contracted support, and they came to your last meeting and were able to outline to you their business structures and how they sit.
Thank you very much. Kate, before you move on, do you mind if we have a short comfort break? My brain is frying and everyone else is falling asleep by the looks of it.
Absolutely not, but Councillor Whelan, I feel like we may have covered the public health and adult social care.
Okay, fantastic. So we'll move on to the next item. Thank you for that, Kate. I appreciate it. We'll have 5 minutes. Okay, it's past. We'll return back to session, guys. So the next item on the agenda is the Housing Authority Enforcement and Civil Penalty Notices. I'll hand over to you, Laura. Thank you.
Thank you very much, Chair. My apologies. I made my screen smaller so that I could see all of the performance report, and now I can't even read the committee report that's in front of me. Councillors, my assumption is that everyone's had the opportunity to review the report. I'm grateful to Ian Lloyd and to Dawn Lang, who join us online, who are far more expert in all matters housing than I am. Dawn and Ian have spent a lot of time combing through some relatively new legislation to understand what that means for us as an enforcing local authority, which is a role that isn't unusual to us in adult social care and housing or as a local authority. What they've done is taken all of the legislation and pulled it together to create an enforcement policy that follows national best practice, aligns with the requirements that we have been cited on that it needs to align with, and also to look at a civil penalty notice policy that enables the council to discharge its statutory duties. The report asks you to approve the Housing Authority enforcement policy, to approve the civil penalty notice policy, and to delegate to me the authority to make minor amendments to the process when required in response to changes in statutory guidance, to changes in legislation, or to changes in case law. So it'll be the legal framework that will govern any changes that are made to the policy moving forward. And rather than that being a matter that reverts to committee, the opportunity for me to execute any of those changes on your behalf. The policies are public documents. They do appear on our website. Any changes will be advertised and people will be notified of them. In addition to being aware as to what the policies say from the outset, this will not come as a surprise to people. They'll know where they've got to look, and we'll support them to understand their obligations at the outset of doing business within this sphere. I hope that gives you some context, and I am happy to take any questions. I apologise in advance for throwing Dawn and Ian into it if I need their expert support.
Thank you, Laura. I've got a couple of questions before I turn over to the committee, but it looks like there are a few questions on the committee too, and I'm conscious of time, so I'll put through these, and if you can't answer them now, or anyone in your team can't answer them, I'm happy to take a response after the meeting. So one of the things that concern me, areas that concern me, is the entry to premises on this. And I understand that this is a legal framework and there are things that we can do to change. However, and I'll just as a reference for the committee, so it's 3.3.2 entry to the premises. And it is the Section 118 Renters' Rights Act 2025 permits council officers to enter business premises of relevant people, including landlords, letting agents, and marketers, if it is necessary for the production or seizure of documents under Section 122 and 123 of the Renters' Rights Act 2025. This power will be exercised without a warrant. Now, that was something that concerned me. I was going to add a little bit to that, please.
Councillor Whelan, you're starting off somewhere right in my wheelhouse. As a former prosecutor, I pay great consideration to any powers around enforcement, and these are not powers that the local authority isn't used to exercising. A number of our staff teams, including my own, our housing renewals team, have powers of entry to people's private residences for the purpose set out in legislation. In terms of executing those powers of entry, we have a really robust scheme of delegation in place, and for people to be able to exercise those hugely impactful interventions with people's fundamental human rights, we have to be satisfied that they're doing so with the right intention and in compliance with the legal framework. What that means for my staff is I personally approve any powers of entry that they have and under that scheme of delegation. That's done in consultation with our legal team and in compliance with the enforcement policy and the overarching legislation. It's something that's regularly reviewed as well, so you don't just get given that responsibility on behalf of the local authority. That responsibility on behalf of the local authority would be allocated to you so long as you are fit and proper, so long as we're satisfied that you can do that with proper due diligence and in line with the requirements of the legislation, and then that's reviewed to ensure that that remains the case. This is a power of entry that we consider. It's something that's necessary to be able to enforce the legislation if there is non-compliance by the individual, but we very much see it as that fundamental intervention with somebody's human rights, and it's weighted accordingly. I wouldn't envisage those powers of entry being executed in any case without discussion with myself and the legal team.
Can I call a point of order or a point of clarity?
Say again, sorry.
Well, call a point of order and clarification. So some of us own businesses. I'm just wondering how this I'm wondering where I stand as a business owner, if I might, if your officers might want to. So I'm wondering whether I should be part of the discussion or not. But if you own businesses and things and they want to come and enforce against you, that's what I'm asking.
This is a policy. Sorry to jump in, Chairman.
Please.
Chair, thank you. This is a policy that relates to specifically to housing. So it would be I would offer a conversation to those councillors who are sat here now, who are landlords, who, if anyone is, I'm not suggesting anyone is, but if anyone is a landlord, it might be something that they want to consider. But otherwise, if it's purely on a commercial basis, then these policies do relate only to dwellings, essentially homes and flats that are for residential purposes.
Thank you for that point. I just heard you talk about, I thought I heard you talk about commercial premises for a moment, but maybe I didn't.
Thank you for that. Just another question on going on to HMO licensing conditions, and this is for page 169 to 170 as a reference if anybody would like to read it. And it's part 3.5, point 4, and it's the conditions that can be added to the HMO license to require work to meet specific standards and to the address. And I understand that there are mandatory situations where the council, basically the national framework with regards to this legislation, but there's also there are also non-mandatory things that we can put onto HMO licensing. So it doesn't come under licensing as you would think it is, it comes under housing. What is the ability for the local authority to add stipulations to the licensings of the HMOs with regards to issues that potentially could arise in the future?
So for HMOs, there's two separate regulatory frameworks that apply. The first, the planning regulatory framework, and a property that is an HMO has to follow the correct planning process. And the second is the use, the HMO itself and how it's used. You're absolutely correct, Councillor Whelan. For an HMO licence, we are able to impose conditions from the national set of conditions, but also discretionary and specific to this local authority. If we were to consider developing our own local authority conditions, my view is that that would be something that we could do. We'd need to consult in terms of what we were looking to include and make sure that there was a consistency, that they were proportionate, that they were appropriate, and that they were signed off by the local authority in its entirety. It isn't something we'd need to put in place at this time to effectively approve the documents before you. But if it was something that the committee wanted to have considered, my suggestion would be that we look to convene a workshop with all councillors to enable them to input into any discretionary conditions we want to look to leverage on HMOs in the future. Retrospectively, I'd need to take advice. I'm not sure we could retrospectively apply conditions to HMO licenses that are out there, but for new licenses, it's certainly an option that would be available to us if we followed the proper process to do so.
The first person put the hand that I saw was Councillor Blake. Is there anyone else who has got any questions regarding this? Councillor Bauer will be next. No? Okay, thank you.
Thank you, Chair. A couple of years ago, I had some casework around this, and it did flag up some inconsistency, shall we say, in terms of the enforcement of this policy or its predecessor. I regret I haven't been able to read the whole report and go through, particularly cross-referencing against the things like before, but what I have been able to do so far, it does look like it addresses some of those issues, particularly around, I mean, what this should be is a user guide for your enforcement officers to go, right, I've got this problem, what do I do? And the last one, I don't think satisfied that. It left too much to discretionary and too much to judgment, which some enforcement officers took one way and others took another. So so far, I think that's been clear. But I think for me, as what I wanted this policy to be a lot clearer in terms of enforcement, not only for landlord's sake, but also for renter's sake and for the enforcement officer's sake. to comment on that.
If I may respond, Councillor Blake, I agree with you entirely. And what the policy does in terms of its update is provide greater accountability in terms of that enforcement activity and clearly outlines the local authority's responsibility. What I would say is it is still a policy, it's not law, and the local authority is able to deviate from policy where it has sufficient justification to do so. There's lots and lots of legislation out there that give us an idea as to what that sufficient justification is, and we would look to apply that in circumstances where it was necessary. But the default position would be the policy is the policy and that's what's applied. I don't know whether, Ben, you want to provide anything in terms of that ruling.
It's okay, Chair. Thanks. Yeah, thank you. And just to echo that point, where you have legislation that provides the council has a duty to do something, it has to do it, has no choice in it. And you heard earlier an example, provision of care is a really good example, is there's no defence to the duty to provide care. The council has a budget deficit, and so it must provide it. And there's lots of case law on that point. Where the council is provided with powers in law to do something, what the council cannot do is fetter its discretion. It cannot say, we will never do these things and we will always do those things. And so the skill of a policy has to be to identify how the council will approach things in terms of priority. And that, I suppose, is the conflict that you mentioned, Councillor Baker, in terms of then leaving it open. But what a good policy does is identify the things that would fall in favour of doing certain things and things that go against. You'll see in these policies, particularly on the enforcement policies, it talks to things that will be taken into account in mitigating circumstances and things that will be taken into account as aggravating factors in determining what action to take. And that's those are really important aspects of a policy. So it's getting the policy wording right, so we don't fetter our discretion. We cannot say we will always do this. We cannot say we will never do that. And so you have to provide the framework within which officers can make the decision.
Very quick supplementary, because I forgot to ask it in my first point. Just where this is a policy, does it have to come back to PFR for approval, or is this it into council policy?
My understanding is it doesn't need to go to PFR. You are the service committee with responsibility for this service area, so it would be this committee that signs off.
Councillor Garrett. Sorry, Councillor Bauer, sorry.
Mine is a general question based on the assumption that with this new legislation, we are not going to be going out inspecting all these properties. So therefore, I had a question in my mind is that when we enforce and inspect, it's likely to be as a result of a complaint from a tenant. What concerns me is if you have someone that's vulnerable, being bullied, they might not wish to make a complaint. In the case of HMOs, where, say, for instance, it's licensed for 12, 15 people, and we end up with 30 in there, those 30 might not want to say, right, we're overcrowded, because they end up with nowhere to live. So I start thinking to myself, is there a sort of whistleblower policy? Can the neighbour phone up and say there's 40 people living in this house and there should only be 10? Is a care worker able to report the fact that they've been into someone's house and it's not up to the right standard and create an inspection regime, or is it purely the tenant that can make this happen?
Councillor Bauer, in the same way as applies under the current policy and under our housing standards work for housing renewal, the referral can come from anywhere. What the team will do is then investigate that and add what weight to the information they receive at that point in time based on their own observations and the evidence available to them. So we currently receive referrals in for housing standards work, our housing renewal team, from police officers, from paramedics, from next door neighbours, from the person themselves, from their son, their daughter, their neighbour, better who takes them to church. That continues to apply. We will accept referrals from anywhere and everywhere. Our job is to make sure that vulnerable people are best protected, and that continues to be our priority. What we do with it and the process behind it will determine how we progress from that point. Just because my next door neighbour says my house is overcrowded, we're not going to send one of our housing inspectors round to execute a power of entry and go in there and start seizing documents. It's about that evidence gathering, triangulating information and adding the appropriate weight. But we will and do and will continue to accept requests for support from wherever they come in our community.
Thank you, Councillor Bauer. Councillor Garrett.
Thank you, Chair. And Councillor Bauer was touching on the very same sort of thing that I was thinking of, but although I was going to go a little bit more specific around the reletting and remarketing of properties within the no-let period. How are we possibly going to be able to police that? Are we going to be just dependent upon people reporting in that because they happen to know the law and something's done, or an aggrieved former tenant might just have kept it? Or are we going to have some form of proactive record of properties that have gone into the no-let periods? Is there any idea on how that will actually work?
I think we're in the territory of suck it and see, if I'm really honest. In terms of some of these things, they're really new to us. Proactivity costs us money. As a council, we don't have money. So we have to balance the potential resource impact against the benefit. We won't know where we are until this stuff is live and active and we're working along those lines. So from a resource allocation point of view, I'll be heavily relying on Dawn and Ian to provide us with guidance in that space. If we go a few months and we see things being relet, this is a small island, lots of people like to tell us lots of things. I'm pretty sure we'll need to review and revisit how we implement some of these areas and the best use of resources in that space.
Well, it is a very new piece of law. Who receives the penalty monies? Is it this authority, in which case we can apply that to the way in which we construct the service that we offer, or is it one of these ones that goes into the bottomless treasury?
I don't know. Dawn or Ian may be able to assist us if they're there.
We are here. Both of us
Dawn
are here.
is there. Dawn, do we get the money?
We do get the money. We do get the money, and as it's been identified, we will keep that money, and that will then be used to effectively fund whatever enforcement processes and we put in place.
I wonder, Chair, if I may just chip in and make it very clear this is not an income generation scheme for the local authority. Over many years, I've borne witness to a number of comments in social media and mainstream media about parking tickets and speeding fines being income generation. That really isn't what this is. This is about meeting the needs of local people and ensuring that they have appropriate, sustainable and suitable accommodation.
Thank you, Laura, and thank you, Dawn. And thank you guys for coming along and staying along for all this time to answer questions on this section. I really appreciate it. So I'm going to seek a proposer and a seconder for the recommendation that the committee approves the adoption of the Housing Authority enforcement policy to ensure a consistent and compliant framework for exercising the council's enforcement responsibilities. Also, that the committee approves the adoption of the civil penalty notice, the CPN policy, to enable the council to meet its statutory duties under the Renters' Right Act 2025, and that the committee delegates authority to the Strategic Director of Adult Social Care, Housing and Coroner Service to make minor amendments to the policy where required in response to changing in statutory guidance legislation and relevant case law. Do I have a proposer? Thank you, David. A seconder? Mr. Blake. Can I have a show of hands for, please? Thank you. It's unanimous. Thank you. Any abstentions? I'll just bear with that. Good. Thank you. Item on the agenda is the Adult Social Care CQC report. I understand that we have talked about this a lot recently. So if you wouldn't mind giving a brief overview, and I know how good you are at that, Laura, of the action plan. We will go to questions, but I'm mindful of time that we're coming up to 8 o'clock. If we prefer to move on and move past 8 o'clock, we'll obviously need to take a vote on that. This report has been available for months, and if there are any burning questions, obviously Laura would be happy to take that. I'll hand it over to you, Laura. Thank you.
Councillors, I've talked to you at great length about the CQC assurance process for what feels like forever. We've had the report for some time. It was shared with you. You had the headlines in terms of our activities proposed to address some of the recommendations that were made by the CQC, and the report in front of you simply pulls through all of those recommendations by CQC theme, area of improvement, and what we're hoping to achieve. You'll see that everything within the action plan has detail behind it. It has a time frame and it has a responsible officer allocated. We've identified some key performance indicators that we're going to track in terms of how we're achieving the improvements that are required. And we've also looked at what our success measures will be. How will we know we're getting it right? The improvement areas are entirely consistent with everything I've outlined for you as a committee before. There's nothing extra that's been added in. There's nothing that's been taken away. In terms of assurance moving forward, as I've previously said, we're proposing to bring this back to you as a committee on a regular basis. And the last appendices is what I'm proposing to bring back. Hopefully you'll find it useful. It tracks delivery as well as any delays. It provides you with a visual overview of where we are, and of course further detail will be available to you in relation to any of those areas. It's our intention that the action plan, together with that plan on a page that ended up being plan on many pages, is available to all of our local residents in the community. Our commitment, if approved by the committee, is to upload it to our website so that it sits there and people can see it, and we'll be updating it once a month after my leadership group meeting to ensure that it provides the most up-to-date picture for people in our community. I'm confident that the actions outlined do address the recommendations made by the CQC. They go beyond what's being suggested to ensure that when the CQC come back and visit us again, we're able to show them with confidence that the areas for development that they identified are areas we've progressed and taken forward. What it also does is build on our self-assessment, which has been published for the last 3 years on our website, picking up some of the areas we think we need to develop that the CQC didn't pay attention to. So we're confident that it will also pick off any of those other areas for development. It was produced with my staff team. They know what's expected. They've all bought into where we are and they know what success looks like. And you'll see there's already been some significant work undertaken with delivery anticipated towards the end of this month, early next month of that first tranche. Happy to take any questions that you have.
Thank you, Laura. Any questions from the committee? Second, sorry.
Propose that I'd like to propose that we vote for them en bloc.
Thank you very much. Do we have a seconder on that? Okay, thank you very much. Just before we do vote, I wanted to quickly mention, I understand that you guys have been, have been working very, very hard to get this sorted out, and we really appreciate it from me, and I'm sure from the committee too, to pass our thanks on to the team for the improvements that they're currently putting in place. I know there is work to do, and there's work to do, and so is the team, but we are grateful that we're getting through that, and of course the whole team under the massive adult social care housing and all of the subjects that we cover with regards to that is really important that we do that. I think okay. So you're proposing the officer recommendation. Is it? We've had a proposer and we've had a second. Was that Claire? Thank you. Can I see a hands for? Against? Excellent. A committee work plan is the next item on the agenda. Is anybody questions with regards to what's coming up in the agenda for in October?
It's got to add the first item that we're intending to bring it back for discussion. So that just needs a.
We've got that on that side, haven't we? So we'll get that sorted. Thank you for that, Councillor. Excellent. Okay, and that is the end of the meeting. Thank you very much, councillors, and thank you, press. And we have a student in the back there. Thank you for turning up and seeing how it goes and how it all works. And obviously, Health Watch, thank you, of course, for coming again. And to our fabulous team and the back office that making sure that this happens at 8 o'clock at night. So I'll call that end of the meeting. Thank you.